Good morning, everyone. The majority of childhood cancer cause is not clear yet, so that's why we choose to investigate the importance of social determinants in childhood patients with malignancies. My name is Miklós Bartók. I'm currently working in a small town hospital. My vision is to prevent childhood cancer, and my mission is to identify and eliminate contributing factors. We have two ongoing studies. The first one is a systematic review and meta-analysis investigating the prevalence of childhood malignancies in different socioeconomic status. Why is this topic important? Although it's a rare disorder, childhood malignancy is the leading cause of death by disease in developed countries, so it still poses a great health burden. One of the most frequently asked questions, how did my child get cancer? Unlike adult, childhood cancer develops from spontaneous or so-called de novo mutations, and we choose to investigate socioeconomic status because there is a well-adopted idea that people from high social classes live longer and in better health than those from low social classes. We run these research on the overall aim to provide some indication for causative factors with in socioeconomic status and childhood malignancies. We came up with a clinical question: what is the prevalence of childhood cancer in different socioeconomic status? We use the PEO framework with population children. The exposure one will be the individual socioeconomic measure. The exposure two will be the ecological socioeconomic measures, and the outcome is the prevalence of childhood cancer. Our hypothesis is that childhood cancer is increased in high socioeconomic settings. We use 5 domains for our search key with overall hit of 25,000 in the 3 main databases, from which we choose 177 articles. Right now we are finished with the meta-analysis part yet, and we are showing you our findings. Based on that, we collected data from observational studies. Therefore, our main findings are adjusted odds ratio. In the following forest plots, I will show you the association between paternal educational level and childhood malignancies. The education of the parents as a measure of childhood socioeconomic status is well described in the literature and used previously as a reliable scale. In the first figure, I show you the leukemia because this is the most prevalent childhood malignancy. The adjustments are in columns, yes or no, indicating if an adjustment was made or not. As you can see, our results are not mathematically significant. In the second figure, the parental education and the central nervous system tumors are shown. As you can see, our findings still not mathematically significant, but there is a visible tendency toward high socioeconomic settings, indicating that it could mean that in high socioeconomic settings, childhood central nervous system are more likely to occur. We have the chance to run multiple subgroup analyses. As you can see, most of our analyses didn't show any significance, but in case of central nervous system embryonal tumors and ependynoma, there is a trend for high socioeconomic settings. For ecological socioeconomic measure, we can say the same as for individual level socioeconomic measures, that our findings are not significant. Here I summarize our strengths and limitations of our study. So several well-established risk factors was used for adjustments, but the adjustment was not uniform. And also different educational system was a main limitation for the individual socioeconomic measurements, and also there is no single gold standard for indicator for socioeconomic settings. Our conclusion is that overall there is no clear evidence for an association between socioeconomic status and childhood malignancies. Therefore, all children need the same medical attention, meaning that we shouldn't look for malignancies based on the family background of the child rather than the clinical signs. And the implication for research that, as I mentioned earlier, because there was a visible tendency, there was a trend in central nervous system tumors, maybe some epidemiologic investigation should be taken place in these children with embryonal tumors and ependymoma. Our second topic is a protocol for a randomized clinical trial. It's a glutamine effect on oral mucositis in childhood cancer patients. Why is it important? Because during active treatment, childhood cancer patients, 50% of childhood cancer patients experience at least one episode of inflammation of the mucous membranes. It is painful, it impairs the ability to eat or drink, it's decreased the health-related quality of life. And why glutamine? Because it is inexpensive, easy accessible, and applicable, and the current evidence is conflicting. Our aim is to investigate the benefit of glutamine on oral mucositis. We came up with a clinical question: can glutamine change the severity and/or occurrence of inflammation of the mucous membrane in the mouth or esophagus due to current chemotherapy? We use the PICO framework with the population children receiving chemotherapy. The intervention is standard oral care plus oral glutamine. The control will be standard oral care plus placebo, and the outcome will be the occurrence and severity of oral mucositis in different, in the WHO grade and the OMA scale, and safety and effectiveness. Our hypothesis is glutamine is an effective prophylactic agent. If our hypothesis proves to be true, then it can decrease the cost of the treatment and increase the health-related quality of life of the children. Here I summarized the eligibility criteria for our study. So basically, we will investigating in children, so under the 28 years of age, and we will exclude patients who are undergoing any other agent which can manifest in oral mucositis, like neck irradiation or head radiation therapy. And we will include patients who are receiving methotrexate and 5-fluorouracil, because these are high potency agents that can cause oral mucositis. The intervention group will receive a pamphlet with an oral care regimen and also glutamine in a given dose. And the control group will only receive placebo and also the pamphlet. So as I mentioned earlier, our vision is to try to provide better quality of life of childhood cancer patients, and with these two studies I will try to contribute to reach my vision. Thank you for your attention. With the word of Peter Attila, who is an ultra swimmer, in life velocity means very little, acceleration means everything. Thank you.
Thank you for the very nice presentation. Are there any questions from the audience?
Thank you very much for the nice topics. I have one question. I'm not an expert on this, but what does standard oral care means in the second case?
Well, we will make a cooperation with the dentistry faculty of Semmelweis University, and they will give us what does a proper oral care mean. So it will be an A4 sized pamphlet with detailed instruction, how many times, how long, with what kind of brush, with what kind of rinse, and what kind of toothpaste. So it will be very detailed. We don't have it yet, so we don't have the pamphlet yet, but I connected the dentistry faculty and they have a very detailed oral care regimen. So it will be, I think, very satisfying for the patient as well.
Thank you.
You're welcome.
I have a question regarding the first project that you said at the end that further studies needed for the assessment of the carcinogenic factors. But what are the hypotheses in the literature? So why should it depend on the socioeconomic status? What's the difference between two families, like diet or physical activity? So what can be the sub-factors for the tendency of a higher prevalence of cancers?
Thank you for your question. Yes, it's a very interesting question, and when we present our data and showing that there is a trend towards a high socioeconomic setting in these patients, usually this is the question which came up, that why? As I scan through the literature, there are multiple hypotheses, but they are proved to be. So one is the hypothesis that the sterile environment that these rich people provide for their children, that they are cleaning everything with disinfection solution and so on and so on. So this hypothesis maybe can be, so the overprotection of the child from infection and so on can be one hypothesis, but it's still debating in the literature, and we really don't know yet. I think if we focus more on these patients, maybe the answer will reveal itself. But right now, I don't have a hypothesis. I'm sorry.
Thank you. I have one more question. In some of your forest plots in the first project, there were 3 data points, but one data point was opposite to the other 2. Yes. So sometime, have you analyzed like what makes those observations so different from the others? So
the answer is that, as I mentioned earlier, our main limitation is that the educational system is very different in each country. So when the dot is on the left side, yes, which indicating that lower in that case that the educational level, so they are comparing the primary versus the secondary, so like 8 years versus 12 years. When there is in Switzerland or in the United States or in Denmark, they are comparing 8 years for 16 years. So they have much more scale. Maybe that could be an answer. And also the first one is also always in Norway. So Norway is a very rich country with childhood poverty under, I think, 2% or something like that. So maybe in a settings where poverty is not a big thing, that everybody is rich, or that the education, as I mentioned earlier, so socioeconomic status couldn't be measured easily. So we just have these indicators for it, but we can't say that if you go to university, you will be rich. It's more likely every case, but we know people who didn't go to university and rich as well. So that's fine.
Thank you. Any more questions? So thank you.
I have congratulations on your presentation, and I have one short question about your second project. Do you plan to measure the quality of life also as an outcome in your trial? As you mentioned that your aim is to improve the quality of life in this project as well.
Well, we choose these incidence and occurrence because these are hard outcomes, and we are focusing more on that. But as a secondary outcome, it's still pending. So it's either the initiation of parenteral nutrition and parenteral fluid, or the quality of life. But in Hungary, these internationally approved quality of life assessment tools, sometimes these are not translated. These are not in the literature, so that's why we have maybe some problems with the measurements of quality of life.